ophthalmology and on dermatology. And they're going into very much detailing as well, which is concerning, I would say. But then no worries, if it is a difficult station for one person, is difficult for everybody. And that's how the marking is going to take place. So we don't need to worry about that. Yeah. Okay. So what you're talking here is in ophthalmology, first of all, the scenarios where we need to go for immediate referral and the scenario where we can go for non-urgent referral. See, one is non-urgent routine referral, that's one. Another, we use the term urgent referral as well. So urgent referral is mainly used for 2 weeks pathway, isn't it? That's we go for cancer, isn't it? Cancer pathway, that's 2 weeks urgent referral. But sometimes we have to go for immediate referral as well. Specifically, if you see an eye, if patient has got blurring of vision, loss of vision, so it's a matter of urgency. You cannot just wait, isn't it? So in that kind of cases, these kind of cases, you'll see you have to go for immediate referral as well. So if a patient is going to come to the A&E, what's going to happen? Patient will be seen by the eye specialist there, or they'll call the patient to the A&E clinic. Or if the patient is coming to the GP, what GP can do, GP can speak to the eye clinic, and whosoever picked the call, for example, the staff picked the call, the GP will explain that I want you or the doctors to see the patient today itself. So it can be immediate referral, the same day referral as well. Patient will be seen by the specialist the same day as well in eye. So immediate referral is there. And you'll see many scenarios, many things where it is immediate referral as well. So if it is acute angle closure glaucoma or open angle glaucoma, scleritis, ocular toxoplasmosis, keratitis, retinal detachment, macular degeneration, optic neuritis, peripheral loss of vision. So here you might be doing immediate referral as well, immediate referral. Peripheral loss of vision, if you see, it is because of say bitemporal heminopia if you have. And we know bitemporal heminopia is mainly because of pituitary adenoma, right? So yeah, in that case, maybe not immediate, but maybe urgent referral we can do, right? Allergic conjunctivitis, subconjunctival hemorrhage, episcleritis, and cataract, nothing urgent. And you don't need to do the referral. For example, for allergic and subconjunctival hemorrhage and episcleritis, you don't need to make any referral. The GPs, they can manage the patient. But if it is cataract, again, we need to make the referral, but it is not an urgent referral. It's a non-urgent referral because even if you're doing the surgery, it's not like you have to do it tomorrow itself. It can take a bit of time, not a big problem, right? So now we understand which is immediate referral, urgent referral, or non-urgent referral. Make sense? Now, how I can divert my station? So should I go into this direction, that direction, or which direction? So this slide is going to be the most important one. You have to see the presenting complaint of the patient. So if you get the presenting complaint, after that you can actually go in that direction. So the presenting complaint is eye pain, or is it eye discomfort? Is it loss of vision? Is it red eye? Or is it blurring of vision? So the presenting complaint will take you towards the diagnosis. Doctor, I've got eye pain. It is pain. So if it is pain, most probably it is scleritis or it is keratitis. It is scleritis or keratitis. I'll tell you in the exam which clincher they are going to give you. If you get that thing, that's your diagnosis. I'll give you the clincher in a while. So if the presenting complaint patient is saying, doctor, I've got pain in my eye, think about scleritis, think about keratitis. Could be bacterial, could be herpetic. How you can find it out, I'll come in a while. If a patient is saying, I've got discomfort, doctor, it's not pain, but it is really like uncomfortable. It's a discomfort in my eye. It could be episcleritis or it could be allergic conjunctivitis. If the patient is saying, I have got loss of vision, so it could be retinal detachment. Also with retinal detachment, patient will give you very typical history, which is curtain falling. That's very important. Cataract will have loss of vision as well, but that is going to be progressive loss of vision, right? Progressive, painless loss of vision. Then patient can have peripheral field of vision loss as well. Patient can have three things. Patient can have tunnel vision. Patient can have bitemporal heminopia, and patient can have homonymous hemianopia as well. Understood. Then patient can have optic neuritis as well. Optic neuritis. So here patient will say, I've got loss of vision, I've got uh, you will see the visual acuity is going to be low as well. Sometimes they will give a bit of pain while moving the eyes as well. So that is something that you will see, but mainly loss of vision. Open angle glaucoma, it's a very interesting thing, maybe loss of vision, but mostly you will see patient is asymptomatic actually. Maybe there is a family history of glaucoma, that's why we are managing this patient. I mean, that's why we are doing the early check and maybe we can find something. Sometimes, not always, sometimes patient IOP might be high as well, increased IOP, intraocular pressure. But sometimes you can have normal intraocular pressure as well. Still, your patient has got open angle glaucoma. Mostly open angle glaucoma presents with no symptom. There is no symptom at all. But sometimes patient can present with loss of vision as well. If it is red eye, patient can have acute angle closure glaucoma. They'll have pain in the eye as well, but mainly the presenting complaint comes as a red eye. So here we'll have red eye. Also, patient can have pain in the eye as well. If they say pain, you think for scleritis, keratitis, also acute angle closure glaucoma as well. But as I said here, the patient will have red eye as a presenting complaint mainly. Right? Then we have got some conjunctival hemorrhage. That usually happens like you woke up in the morning and you saw like one of the eyes red. Maybe I was coughing or I was just putting the water in my eyes just to clean it and I saw it's red. Now, when you have got subconjunctival hemorrhage, you have to see, is it in one eye? Is it in both eyes? Is it in one eye? Is it in both eyes? If it is in both the eyes, it's a red flag sign. Check if the patient is on any blood thinners. And if it is in both the eyes, it could be an early sign of TIA or stroke as well. If it is in one eye, nothing to worry about it. It's going to get better in a few days' time. Just lubricant eye drops you can take. Otherwise, if it is in both eyes, it's a red flag sign. Now, if patient is saying, I've got blurring of vision, you have to think about ocular toxoplasmosis and you have to think about macular degeneration as well. Age-related macular degeneration. Here, patient will give you the history of blurring of vision, or patient might say, I just see these wavy lines as well, and patient will have loss of central field of vision. Right? So now, it depends on the presenting complaint. Doctor, I've got pain in my eye. Tell me more. Pain, if it is going mostly towards scleritis, keratitis, and maybe acute angle closure glaucoma. These three things I'll be having on the top of my list. My patient is saying no pain, discomfort. I'll think about episcleritis. I'll think about allergic conjunctivitis. My patient is saying loss of vision. It could be retinal detachment, curtain falling, painless progressive loss of vision, cataract, peripheral loss of vision, which include tunnel vision, bitemporal heminopia, homonymous heminopia. In these cases, patient may not have symptoms at all. They may not realize they have, but they may not realize the symptoms. Symptom could be loss of side of the vision. So what happens because of that? They're bumping into people, they're bumping into the wall, they're getting accidents quite frequently. That could be the presenting complaint. Optic neuritis, again, visual acuity is low and they'll have pain maybe while moving the eyes. That could be the history as well. Red eye, think about acute angle closure glaucoma, think about subconjunctival hemorrhage as well. Of course, red eye, you will have an allergic conjunctivitis as well, but then patient will give you the history of eye discomfort and all as the first thing. Red eye is mainly acute angle closure glaucoma and subconjunctival hemorrhage. Blurring of vision, toxoplasmosis, and macular degeneration. Don't miss out on these things. Okay. Now, uh, okay. So scleritis and episcleritis. It's very difficult for us to diagnose while looking at the pictures and all. Just remember if the patient is saying eye pain or if the patient is saying eye discomfort, so you can diagnose it accordingly. Usually scleritis, episcleritis, you elaborate the pain, do Socrates, ask other symptoms like eye pain, eye discomfort, loss of vision, red eye, blurring of vision, ask everything. You may not have other things much of positive. So how I'm gonna conclude it? Here, scleritis, episcleritis, what you will have, I'll show you one thing. You have a history of, come on, where it is. So what is important is here, you will have a history of RA or IBD, and this patient is taking methotrexate, for example, any immunosuppressants this patient is taking, which is gonna be the reason your patient has got scleritis or episcleritis. The treatment is you need to work on this RA and IBD, make sure you control it. Maybe you need to make some changes in the dosage of the methotrexate, and you might be giving corticosteroid because patient will have pain, patient will have too much of inflammation as well. That is the main thing. So what I'm trying to say here, so if your patient is giving you the history, I've got eye pain. So you are thinking about, is it scleritis or episcleritis? That is deciding, that we are deciding on eye pain or eye discomfort. In both these, you will have a history of past medical history. Patient either will have RA or IBD or whatever, and patient is on methotrexate. Sorry. Sorry, guys. Ah, so sorry. Yes. So patient will have the history of RA, IBD, and this patient is on methotrexate. So that is gonna be a tincture for you if you have to go towards scleritis or episcleritis. Now, keratitis. So here, patient is saying eye pain, but you didn't get anything in the past medical history. You didn't get anything in the past medical history. Herpetic infection. What you need to ask in the past medical history if this patient has got a history of genital herpes in the past, any herpes infection in the past. Now, you might be thinking if I ask this question straight away, I might sound scripted. The thing is not really. See, when patient has got eye pain, what comes in my mind? My mind says scleritis, my mind says keratitis. When I ask my patient if he's having RA, he's taking methotrexate, IBD, he's saying no, 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 no. So scleritis, episcleritis is kind of out of my list. Now I have to look for other infection, which is keratitis. Bacterial or herpetic. So how can I find it? Fever alone I will ask. But if the patient has a history of genital herpes, in the lifetime, any time in the life, they are actually prone to get herpetic infection anywhere in the body. It could be herpetic eye pain, herpetic keratitis. It could be herpetic whitlow infection in the finger as well, or patient they are prone to get herpetic infection again as genital herpes as well. So we have got a scenario that comes quite often in the exam, which is herpetic keratitis. How are you going to diagnose it? Presenting complaint is eye pain. In the past medical history, you'll have a history of genital herpes in the past. That actually gonna guide you towards herpetic keratitis. Okay. Episcleritis, again, you'll have a history of methotrexate, and presenting complaint is discomfort. Allergic conjunctivitis, discomfort in the eye, a bit of redness in the eye, a bit of gritty sensation in the eye. That's what you will have. Nothing to worry. You can give some lubricant, some antihistaminics, and our patient is going to be better. Nothing much you have to do. All right. Open angle glaucoma, as I said, it is symptomless, asymptomatic, no symptoms at all. Sometimes IOP may be high, but sometimes that's normal as well. Okay. Retinal detachment, curtain falling. That's the main thing that you will have here. Surgery is the only treatment. Cataract, painless, progressive loss of vision. Lots of risk factors. Age is a risk factor. Diabetes, hypertension, smoking, alcohol. All these are risk factors that I'm going to discuss. Peripheral loss of vision. Peripheral loss could be tunnel vision, bitemporal hemianopia, homonymous hemianopia. But then patient may not realize it. They usually don't have insight when they have peripheral field of vision. So what you need to do in this, you have to think and ask question. If you're bumping into people, bumping into the wall, getting more of accidents and all, that's going to be quite interesting. Optic neuritis, I discussed a bit in MS as well. So low visual acuity, pain while moving the eyes. Toxoplasmosis, that's blurring of vision, floaters they might have, and when you ask psychosocial history, this patient is living with the cats. So that will be guiding you towards toxoplasmosis. Yeah, macular degeneration, wavy lines, and the loss of central field of vision. Right. See, my aim here is not to make you ophthalmologist. My aim is just to make you pass in any ophthalmology station if you get in your exam. Now, to make your life easy, I'll say one more thing. The station which comes as a combined station, I'll tell you. So, combined station. So, fundoscopy. I'll tell you which stations are coming as a fundoscopy station. Number one, you are having a GCA scenario where fundus is normal. So, that scenario is coming with fundoscopy mannequin. Another one is retinal detachment, right? So, fundus will be showing you, of course, retinal detachment. History is telling curtain falling, so I think you know how to do it. Yeah, that's the second scenario. Third scenario, if you remember, I told you you're having intracranial hypertension. That station also coming with a fundoscopy mannequin. So what do you think on the fundus you will get? Tell me, you guys tell me. In fundus, what you're gonna get in this scenario? Tell me. Tell me, guys, intracranial hypertension in the fundus, what I'm gonna get? Come on, tell me. And the fourth one that we are having is papilledema. Perfect, good one. So you may have papilledema, right? And the fourth one we have got is ocular toxoplasmosis. And what you'll have on the fundus, you'll have the changes of toxoplasmosis. So if you ask me, till now, they have given us these four scenarios only. Right? In the exam, only these four scenarios have come with the fundoscopy mannequin. Right? Can they give me anything? Yes. The eye mannequin that we have got, it has got 36 findings. They can give you anything. I'm not saying they're not giving other things. And recently they started giving another one. Patient is having diabetes. So what do you think on the fundus we have got? It is a diabetic retinopathy one. So that's a recent one they have added. So these are the 5 findings they are giving us. They have given us till now in the fundoscopy mannequin. So what I'm trying to say is when you enter into the cubicle and you saw there is an eye mannequin. So what do you have? You either have GCA, retinal detachment, intracranial hypertension, ocular toxoplasmosis, or it's a diabetic scenario. So I'm just trying to narrow it down for you. Yes, doctor, tension headache also, I can add that as well, but you have got nothing in the fundus. The fundus was there also normal. So I wrote in GCA, they can give in GCA, they can give you tension headache as well, but that's also gonna be normal fundus. So only 5 findings you need to check, not more than that, just the 5 findings, right? I know it has got 36. I can send you the booklet which has got all 36 findings with the proper history and everything. I can send you that, no problem, right? But concentrate on these 5 findings: normal fundus, retinal detachment, intracranial hypertension, papilledema, ocular toxoplasmosis, and diabetic retinopathy. These 5 findings are the most important one. So when you see this eye mannequin, your mind is going towards this diagnosis, right? Another the combined station that they have got, they give you an wide head pin, actually, wide head pin, and you'll have a Snellen's chart. So that's the knowledge they are giving us, that is peripheral loss of vision. So that is the scenario they are giving it to us. So there you do X test. X test. You can see the videos online. So we have got that scenario as well. So that is again gonna be a hint for you. So I think I was trying to simplify it for you. Like, firstly, enter into the room, check if I have got a mannequin or not. If you have a mannequin, you can narrow it down. Now see the presenting complaint. What is the presenting complaint? Eye pain, red eye, loss of vision, discomfort, blurring of vision. So what you can do, you can narrow down your differentials accordingly, right? So I think in the first minute, you'll be left with only 2 differentials, maybe, not more than that. So this is what I was trying to do. So acute angle closure glaucoma. So here they give you a picture later on because the presenting complaint in the exam, the patient has got a red eye. So he'll elaborate the red eye. And this patient will give you other symptoms of acute angle closure glaucoma as well, which are pain in my eye, pain at the back of the eye, color halos around the light, red eye, nausea, vomiting. The patient is going to give you so many other things as well. And when you say I would like to examine, they'll show you a picture which will be like red eye and dilated pupil. That's what you will see. Right, so it's acute angle closure glaucoma. The aim is we have to increase the excretion and decrease the production of fluid. We have to constrict the pupil, and that's it. And painkillers and antiemetics, right? So timolol is gonna decrease the secretion. Pilocarpine is gonna constrict the pupil. Acetazolamide can be given as well, and then surgical treatment and all, and painkillers, antiemetics that you can give, right? Remember one thing, guys, in this, as the presenting complaint is red eye, what this patient is doing, sometimes you will see this patient is, when you entered in the cubicle, this patient is actually wearing dark goggles. Because if I'm sitting, if I'm your patient and my presenting complaints, doctor, I've got red eye, you won't trust me because my eyes are not red. So in the exam, so that the station will make more sense, what they do, they make sure the patient is wearing the glasses. So when patient is wearing the glasses, life becomes easy for you, right? So that's what happens. Yeah. Okay. Another thing is open angle glaucoma. As I said, this patient might be asymptomatic at all. Asymptomatic, that's the main thing, right? But in the exam, they have given like the patient IOP was a bit high. So that makes our life easy. Yeah. And in this, what you have to do is immediately referral, and treatment is surgical or laser treatment. Obviously, later on, pilocarpine, all those things can be given as well. But main thing, the first thing is the laser treatment or the surgical treatment that you have to go with. Yeah. Subconjunctival hemorrhage, it is a red eye. So presenting complaint is going to be red eye, and usually unilateral, my friend. So if it is bilateral, it is a red flag sign. It's a red flag sign. Hemorrhage in both the eyes, subconjunctival hemorrhage in both the eyes, it's a red flag sign. It's a stroke sign. Patient might be prone for stroke in the future. So you have to be extra careful on that. Yeah. So if it is unilateral, nothing to worry, right? But ask if the patient is on any blood thinners or is it in one eye or both? Yeah, that's important. And if you're triggered by cough or sneezing, or you're putting water too much, like sometimes when we wake up and we just put pressure, with the pressure we put water in our eyes, that could be the reason as well, right? Do they give picture for subconjunctival hemorrhage? Yes, doctor, they give the picture as well. Have a look. So they will give the picture as well. So what I was trying to say, the station that I showed you, these, they are coming with the eye mannequin, the fundal mannequin. And these station like acute angle closure glaucoma or subconjunctival hemorrhage, that comes with this kind of picture. They give the picture of the patient in the exam. That's how it is gonna be. What is the treatment for it? A subconjunctival hemorrhage? Nothing actually. Lubricant eye drops. It is going to subside on its own. It may take a few weeks, few days. That is it. But give the warning sign if there is a pain, severe pain, or if you see the same thing in the other eye as well, come back to us straight away. And that's going to be the important one. Yeah. Cataract. What happens in cataract? As you said, it is a painless progressive loss of vision. That's the thing. Glaucoma, we need to mention tonometry. Yes, doctor, then only we'll be able to find out the pressure and all. Yes, you have to. Yeah. But again, what I was trying to say, open angle glaucoma, you may still have normal IOP. Yeah. For peripheral, I'll come on peripheral field of vision, doctor. So cataract, it is painless progressive loss of vision, right? That's what you have. And the reason is could be anything. Past medical history, if you go, it could be diabetes, high blood pressure, and then smoking, diet, not having good diet, not physically active. So that could be the one. And what else? Patient is taking steroid for something for a very long time. So that could be the reason as well, right? So all these things you will see as a risk factor, right? So what you have to do is, if it's a cataract, you have to go for surgery only. That's the only thing, surgery. So if the patient has got cataract in both eyes, are you going to do the surgery in one go, or are you going to have some, what do you say, sometime you'll have some break as well. So there has to be at least 6 to 12 weeks gap in the operation. So if I've got cataract in both eyes, you're not going to operate both the eyes at a time. You're going to operate only one eye, and you wait for 6 to 12 weeks, and then only you can operate the other eye. That's very important thing. Now the question on cataract usually comes on DVLA. Have a look. So DVLA. So if I'm having a cataract, can I drive or not? It depends on few things. You don't need to tell DVLA if you have cataract in only one eye unless you also have a medical condition in the other eye or you drive for a living. So if you own your own car and you're just driving for your own thing, you don't have to inform DVLA, right? Uh, but if you're driving for a living, like you're driving a Uber or you're driving a bus, lorry, you have to inform DVLA. And if you have cataract in one eye, but other eye also has glaucoma or some other problem, then also you have to inform DVLA, right? So every patient is not going to inform DVLA. Only like a few patients, they are gonna inform DVLA. So that is the criteria here. And the question keeps on revolving around this particular point in the exam. Okay. Macular degeneration. So it's going to be wavy line. Blurring of vision mainly is a wavy line this patient sees. Sometimes the presenting blurring of vision or the wavy line. That is the thing. So it could be dry ARMD, age-related macular degeneration. It could be wet, age-related macular degeneration. All right. So what happened is in these kind of stations, when you do the eye examination, you say, I would like to do fundoscopy, they will tell you the patient has got drusen's. You don't have to do fundoscopy in this station. I mean, till now, they have not given fundoscopy mannequins in this station. It is like they give you the finding. The examiner says on fundoscopy, we have got drusen's. So drusen's means macular degeneration, right? Drusen's means macular degeneration. And drusen's are seen mainly when it is dry ARMD, dry ARMD. When it is dry, you have to do no treatment. But when it is wet, then you have to go for intravitreal injections and all. So when it is dry, what is the treatment? Treatment is visual aids that you can give. This patient has got central loss of vision, blurring of vision, wavy lines. For the treatment, we can make the things better for the patient and we give visual aids to this patient. That is the main thing. Understand? Another thing we have got is allergic conjunctivitis. As I said, what's going to be the presenting complaint? Presenting complaint is itchiness. Presenting complaint is eye discomfort. That is the main thing. They have gritty sensation in the eye. That's what you will have in this, right? And rest, everything is negative. You ask other things, nothing is going to be positive in this. So mainly is avoid triggers, avoid rubbing, cool compressions, topical antihistaminics. That's it. I mean, you have to go with it. Yeah. Scleritis. So what I said in scleritis, what you can have is past medical history of methotrexate. Presenting complaint is eye pain. That is the main thing. Right? Treatment is corticosteroids and all you can give. Another thing that we have got is the sorry, okay, let's have some questions. In the fundoscopy station, we are going to get pictures as well, or we have to make up our mind from the examination findings. Doctor, in the fundoscopy, if the fundoscopy mannequin is there, you are expected to think the diagnosis is going to be from these. That's what they're giving you in the exam. These are the findings that comes with the fundoscopy mannequin. So you have to do the fundoscopy. You have the history as well. You have the fundoscopy findings as well. On the basis of these two, you'll be able to conclude your diagnosis, right? Wet macular degeneration. So wet macular degeneration, you will. What do you mean? Right. So what's your question? Wet macular degeneration findings, please, and which visual aids, please? The visual aids depending on the symptoms, doctor. So if you got what kind of blurring of vision, so they will give, I mean, they'll check the eyesight, where is the problem, and then they can give like cylindrical problems, spherical problems, so whatever the problem the patient has got, they will be able to give the glasses according to that. Sometimes you will see the patient has got altered color vision and all, so they'll try, and these patients as you see these patients in the later, elderly patients. So whatever visual aids they can give, they will give. Wet macular degeneration. See, they may not. So what you will be able to see on the fundus, is that what you're trying to ask, doctor? Is that the question? The thing is, drusen's, that is only seen in the dry one where there is no leakage. There you might be able to see the leakage in the fundus. That is the main thing. But drusen's, no treatment is required. That is the thing. You just have to wait and watch. Nothing much. Yeah. Scleritis, as I said, the presenting complaint we are looking for is gonna be eye pain. So when you're looking for eye pain, it is gonna go more towards scleritis and keratitis. But then in past medical history, I got methotrexate, so that is taking me towards scleritis, right? What is blepharitis? Blepharitis is a kind of dandruff in your eyelid, yeah? So you'll see red eye or itchy eyelid, gritty sensation, sticky eyelid, crusting of eyelashes. That's something that you will see in blepharitis, yeah? Again, the treatment wise, you just have to clean this with the wet, warm compresses, wet, warm cloth. You just have to clean it regularly. That's the main thing that you have to do, right? Cleaning the eyelids is the treatment for blepharitis. Ocular toxoplasmosis, here, this station, as I said, it comes with the fundoscopy mannequin. It is very tricky to make the diagnosis. Now, I'll tell you one trick here. Patient presenting complaint could be blurring of vision. This station comes with a fundoscopy mannequin. Now, in this, one of the main thing that they give it to us is this patient is living with a cat. But the thing is, how I'm gonna ask that question? You cannot ask it directly, like, do you live with cats and all? So now tell me one thing, if a patient is coming to you having loss of vision, blurring of vision, severe pain in the eye, do you think it is going to make sense if I ask a question, whom you are living with? Do you live alone or do you live with somebody? Because loss of vision if patient has got, I have to think twice before I send this patient home, right? So how that history is going to come out? So whenever you have got the station like blurring of vision, loss of vision, severe pain in the eye, ask the patient whom you are living with. And this patient give you very critical history. I'm living with the cats. Living with the cats. So it is a risk factor actually. It is a risk factor. If somebody is managing the cat feces, raw meat, somebody is pregnant, immunocompromised, so they are prone to get ocular toxoplasmosis as well. And when you obviously do the fundoscopy, you will have the typical changes of ocular toxoplasmosis on the fundus as well, right? I'll send you the pictures and everything, the full slide, which has got all 36 findings. I'll send you so you can read about ocular toxoplasmosis as well, right? So here, blurring of vision, floaters, sometimes they will give you the history for, and cat, this patient is living with the cat. So that is something very important, right? If the patient is pregnant, patient is immunocompromised, we might be giving antibiotic treatment as well. Otherwise, it's going to subside on its own. Nothing much you have to do in this, right? Or painkillers and all, you can give some lubricant eye drops you can give for any discomfort in the eye. Yeah. Retinal detachment, as I said, this station also comes with the mannequin, right? So here patient will say vision loss, but they might say like, I've got curtain falling as well. They've got curtain falling as well. That is the main thing going towards retinal detachment. Surgery, surgery, and surgery for the retinal tear. Yeah. Now, another scenario that you have got is the keratitis. So keratitis, the presenting complaint is again, as I said, eye pain. Eye pain, I'm thinking about scleritis and keratitis. Fine. But here, what's going to happen? In scleritis, I get RA, IBD, methotrexate. Here, keratitis could be bacterial, could be herpetic. And to be honest, it's not that easy to make the diagnosis if it is bacterial or herpetic. To conclude the diagnosis, maybe you have to go for corneal staining culture, then only you'll be able to make the diagnosis. In our exam, this patient is always giving us the history of genital herpes in the past. If the patient had genital herpes once in their lifetime, they are prone to get herpetic infection all their life, which can be herpetic keratitis, it could be herpetic whitlow, it could be herpetic anything. I mean, they are prone to get. So that is one thing very, very important. Treatment is eye drops, antivirals, sometimes steroids, and just make sure of hygiene you take care of, right? They have got these two stations as well, Arcus Senalis or KF rings. I mean, these stations, whenever these station comes, some of the candidates, they say, no, it was Arcus Senalis. And I've got a couple of candidates, they were saying, no, it was a KF ring. So, see, these patients, they may not have any symptoms at all. It is asymptomatic. But when you see the eye, you will be able to see things. Here you will see white or gray arc that is on the side if you see this one. Here you will see the golden brown arc. So that is only cosmetically you will see something, but overall patient may not have any symptoms in terms of vision. Arcus senalis, the cause is lipid deposition. Lipid deposition, that's the main thing. So these patients, they may have high cholesterol. So that is something that you need to take into consideration. So there is nothing that you have to do in terms of treatment because patient is not having any symptom. It's just a cosmetic thing. But there might be underlying cause, which is cholesterol. So just try finding that out and then treat it accordingly. If you see KF ring, patient will not say white or gray. Patient will be going for more of golden brown covering. That's the thing. Yeah. And this is the underlying cause we actually look for as a Wilson disease. Treatment is again nothing much, but you have to treat the underlying cause. If it is Wilson, so you have to treat Wilson disease according to the management. I mean, just the chelating agent like what is it, penicillamine and arginic acetate. So that is the main thing. So some said it was Arcus senalis, some said it was KF rings. But mostly what I got from the candidates, I think it was Arcus senalis. And mostly candidates said Arcus senalis. Few of them said it was KF ring. So I'm also thinking it was Arcus senalis. This is after talking to the candidates. That's what we understood, right?